Well, hey there, Papper people. It is me, Lanky, your favorite registered polysomnographic technologist. Now, I'm Jason, and welcome to my channel, Lanky Lefty 27. Hopefully you guys watched my last video. In that video, I went over a bunch of sleep studies. Let me just refresh your memory. If you watched the video, which I will link in the description box, I found that of 396 sleep studies in a sleep lab, of those, I'm just gonna go over the big ones, 20% had nothing, no diagnosis whatsoever. 20% were diagnosed with severe sleep apnea. It's an apnea-hypopnea index of 30 or greater. But I also found that mild sleep apnea, so an AHI, apnea-hypopnea index of 5 to 15, there were 32% people in that category. Then if we add the other 9% that had upper airway resistance syndrome, that puts us at 41% of people who visit a sleep lab are in the mild category of sleep apnea and upper airway resistance syndrome. Why do I mention that? Because in this video, I'm talking about something that is so important, upper airway resistance syndrome, or as some of you say, YARS. And in this video, I'm gonna show you why upper airway resistance syndrome is the iceberg of sleep disordered breathing. It is way worse than you think. But before we get into that, first, give me 1 second. I'm gonna try to sell you something. Guys, are you looking to save a little bit of money, a little scratch this holiday season? Check out the sponsor of this video, cpapsupplies.com. Oh, Jocelyn, you need to put it on. I'm not gonna put it on. Jocelyn, you're contractually obligated. Put on the hat. I'm not putting it on. Jocelyn, if you don't put it on, I'm walking and you'll have to use Boof McTavish. You're not gonna do Boof McTavish. Guys, are you looking to save some scratch? Check out cpapsupplies.com.
Hey, I hear Boof McTavish is needed.
Oh my God, not Boof. With discount code TurkeyLanky20, you can save 20% off all masks and accessories.
Boof is making note of Turkey Lanky 20.
Unfortunately, that does not include CPAP machines.
Boof is not excited by this, but I'm willing to wait it out.
But don't let that get you upset. 20% off all masks and accessories.
Boof is excited to hear more.
For example, you can take a look-see at the Fisher & Paykel Bravida. Ooh, the Bravida mask is super quiet.
Jocelyn, you're actually showing the Vatara. Sometimes I feel like I'm the only one here that's even trying anymore.
Probably one of the quietest masks on the market. If you're not a big fan of having things up over the bridge of your nose, it is a fantastic option. And with discount code TurkeyLanky20, you can save 20% off. They also have great programs such as loyalty rewards, 30-day mask guarantees, as well as a price match guarantee. That's even something that Boof McTavish can get a little bit excited about.
Boof McTavish says, yes, me likey, sign me up.
Okay, first, what is upper airway resistance syndrome? Well, it's been described as being a subtle respiratory sleep disordered breathing event. I would actually disagree with that. I don't think it's subtle at all, but by the looks of it, and this is why I call it the iceberg of sleep disordered breathing events, it doesn't look like much, but there's so much more under the surface. I think a good way to look at this is let's compare it to obstructive sleep apnea. Now here is an actual screenshot of one of my type 2 studies. This is an obstructive sleep apnea event. Now if we look at the breathing line, there's a complete cessation of breathing here. There's no air flowing at all. You can see the respiratory belts. The person is trying to breathe here. We have an oxygen desaturation of 4% or more, although that's not required for an obstructive sleep apnea. And if we look at the EEG, the brain activity, you can see that it's really speeding up quickly. This is showing that the person is waking up. Not good. You have a lot of these. Obviously, the person is going to be super tired in the morning. They're going to have cognitive problems during the day as well. Just two of the major things: daytime sleepiness, cognitive impairment. Let's keep it simple. Next up, we have the obstructive sleep hypopnea. Now, hypopnea, hypoapnea, it's slightly less than an apnea, meaning some air is getting through. Now, the exact definition of that is a 30% decrease in the breathing flow rate. So basically think of it as breathing gets shallow, and then we have more or less the same criteria. The person wakes up, you can see the rapid EEG, which denotes the person is waking up. That's also actually not required for a hypopnea. Then you have a 4% or more oxygen desaturation. Now there's different rules for this. I'll actually get into that in just a second. But again, you're gonna have the same thing. You're gonna have cognitive impairment. This person's gonna be super sleepy during the day, among other things. Now let's take a look at a respiratory effort related arousal. Now, respiratory effort related arousal is pretty much just like a hypopnea. You're gonna have a decrease in breathing. The person is going to wake up. It's in the definition, respiratory effort related arousal. So we can still see the same thing. EEG is spiking. What we don't see is an oxygen desaturation of 4% or more. It's gonna be 3% or less. However, the person is still waking up. They're still feeling like crap. They're still gonna have cognitive impairment during the day. They're still gonna be sleepy. So how is it different than an obstructive sleep hypopnea? It's not. So why is it looked at differently? I don't know. Let me first define apnea-hypopnea index and respiratory disturbance index, as these will come into play in just a second. Apneas, hypopneas, doesn't matter what kind. Number of apneas and number of hypopneas that you have per hour of sleep. So if I have 5 apneas, I have 5 hypopneas, that's 10 total. I only slept for 1 hour, that's easy. My apnea-hypopnea index is 10. Now if I had those same 10, but I slept for 2 hours, now you're obviously gonna cut it in half, it's gonna be an apnea-hypopnea index of 5. That's how it works. Now let's talk about respiratory disturbance index. It is going to include those same apneas, it's gonna include those same hypopneas, but now it's also going to include respiratory effort related arousals. So what if I had that same 2 hours of sleep and I still had 10 apneas, I still had 10 hypopneas? It gives me an RDI of 5.0, but what if I had, I don't know, let's say 100 respiratory effort related arousals? Well, now my apnea-hypopnea index is still 5, it's still pretty low, but now my respiratory disturbance index is up slightly above 50 per hour. So a respiratory disturbance index includes all apneas, all hypopneas, and all respiratory effort related arousals. Now, why do I mention this? It's because this is the first level of frustration with upper airway resistance syndrome. Medicare really doesn't recognize it at all. They have no interest in treating it, as they don't feel that it's an actual disease in sleep medicine. Now, you could be a skeptic like me. I think they're just trying to decrease the number of people that get treatment and not spend money on it. That's just where my mind goes, because why would you not want to treat it otherwise? But that's for another video. Actually, I've already done that video of why Medicare wants to kill you, but I'll leave that for that video. So you could be one of those people who has Medicare, your apnea-hypopnea index is at 5 or below, but you have a respiratory disturbance index that's much, much higher. You're not going to get treatment. That's the first layer of frustration with upper airway resistance syndrome. By the way, I didn't mention this, high RERAs usually equals the diagnosis of upper airway resistance syndrome. Now, this is also going to include insurance companies that use Medicare guidelines. So basically they just are kind of lazy and they just follow the rules of Medicare. So if Medicare doesn't see RERAs or acknowledge RERAs and upper airway resistance syndrome, then they're not either. So these people can still get treatment, but it requires another step. Your doctor has to be savvy in the field of sleep medicine. So if it's your primary care, it's probably not gonna happen. But you can have doctors that will petition Medicare and still get treatment. They'll still obtain treatment and get Medicare to pay for treatment for their patients if they use the appropriate words. Now, another thing that is very frustrating about upper airway resistance syndrome and the scoring of respiratory effort related arousals are sleep labs that use different scoring criteria. Now, there's a different set of scoring where they have, instead of a 4% hypopnea rule, they have a 3% hypopnea rule. I don't want to get too into it, but basically these labs typically do not score RERAs. So you can have hundreds of things that would normally be scored as respiratory effort related arousals that are not scored as anything other than spontaneous arousals or leg movement arousals. This is something I see all the time. Someone will say, God, I feel so tired, I didn't get a diagnosis. Oh, does your lab score RERAs? No, they didn't. I don't see that on there. Or the apnea-hypopnea index and the respiratory disturbance index are both the exact same number. that's a dead giveaway that they don't score RERAs. These RERAs that are not scored are actually going to be hidden, and I mean they're going to be reflected in the spontaneous arousal index as well as the leg movement arousal index. Quickly, why this happens is person wakes up, they look before it. Oh, was there a decrease in airflow? Oh, yes, there kind of was. Yeah, but oh God, the oxygen desaturation wasn't enough. So they woke up, spontaneous arousal. Or all that didn't happen. Oh, they kicked their legs here, then they woke up, leg movement arousal. Usually that's going to ballpark you as to what your true respiratory disturbance index is. All right, back to Medicare. Medicare doesn't think upper airway resistance syndrome is a thing, so it must not be a thing, right? I would highly advise you to look up Dr. Christian Guilleminault. Unfortunately, Dr. Guilleminault passed away in 2019. I did have the pleasure of meeting him once at a conference. Seriously, delightful dude. What he found is that upper airway resistance syndrome is its own distinct diagnosis. He was even quoted as saying that upper airway resistance syndrome is not on a continuum between snoring and obstructive sleep apnea. So you remember before when I said, and I think I've even said this in other videos, and I say this to keep it simplified, completely stop breathing with a big desaturation, slightly stop breathing with a big desaturation, then a RERA, slightly stop breathing, but not a huge desaturation. It's not on a continuum like that. And then below that, you'd have snoring. It's not on a continuum like that. UARS is its own separate thing that really sucks. I would say at this point, Dr. Barry Krakow is probably the next person that has done a lot of research on upper airway resistance syndrome, and it's very much a part of his practice. Though I think he just retired. So you'll see a lot of literature and articles by Dr. Barry Krakow as well. All right, now let's talk about treatment of upper airway resistance syndrome. A lot of the people that I see at AXG Sleep Diagnostics when I'm doing an Oscar PAP therapy analysis, keep in mind, these people are frustrated. They've been using CPAP. CPAP doesn't work. They'll try increasing the pressure. It doesn't work. There's a lot of things that they've tried and it doesn't work. And this is piled on top of, hey, doctor, I have this thing. I can't sleep. Yeah, we're not going to pay for it because it doesn't look like you have anything. This patient population also tends to not look obese. You look at them and you don't say, this is someone with obstructive sleep apnea. But their sleep is very fragmented. They tend to be very thin. They often tend to be young. Sometimes they do have obstructive sleep apnea, but they have an underlying upper airway resistance syndrome. It's different. You now have a massive decrease in pharyngeal muscle tone, meaning you're going to get a collapse from all directions, not just top to bottom, not just side to side, but from all over. It's going to crimp in, and that is a difficult airway to open up. So many of these people get put on CPAP or auto CPAP, and I'm just going to say this, I've said it before in many videos, an auto titrating CPAP is not going to do anything for these people. It's pretty decent at seeing very clear obstructive apneas and hypopneas, but if it does finally get to the right pressure, it's just going to start decreasing really quickly after. I've showed this, documented this in other videos I've done, so I'm not going to belabor the point here, but it never really sees those subtle breathing events such as respiratory effort related arousals. So instead of having these full-blown events, these people just struggle and suffer on CPAP throughout the entire night, slowly underbreathing, gasping and waking up, slowly underbreathing, gasping and waking up, all throughout the night. Reported AHI on the machine, you guessed it, super low. So the doctors are happy. Hey, you're doing great. Just keep up the great work. You're doing great, champ. But the person with upper airway resistance syndrome is saying, yeah, but I still feel like crap. And they're like, but you're doing great. Keep it up, champ. And nothing's more frustrating than that. If you happen to be watching this, please chime in. I don't want to misrepresent your point of view on this. But from what I understand, Dr. Barry Krakow says that ASV, adaptive servo ventilation, it's a more advanced form of bilevel, typically used for the treatment of complex sleep apnea or Cheyne-Stokes respiration. Dr. Krakow feels that ASV is a better option for people with upper airway resistance syndrome. And I would actually respectfully disagree that it is not the best treatment for it. And I'm going to say why. I've seen a lot of people trying to treat UARS with adaptive servo ventilation, and this has actually had me come to my conclusion that is different than Dr. Krakow's. What ASV does is it has a set lower pressure of EPAP, and then the IPAP is goes up and down, up and down, up and down, all over the place. Now that's great for a clear airway event when there's no actual physical obstruction, but it's more neurological. But when you have a collapsing airway around it, it's going to require a lot more pressure to open it up. And it's really just like an auto CPAP. It doesn't really do well at fixing or opening up the airway for those very, very subtle sleep disordered breathing events like RERAs. Now, what I've seen is people using ASV to treat UARS, and what happens is they're slightly under breathing still, but every now and then the ASV kind of dorks up a little bit, and the IPAP gets stuck up in a high position, and it will trend along at whatever that level is. The EPAP will trend along at whatever this level is. Basically turns into a bi-level in spontaneous mode, different than ASV. And during those periods, their breathing looks absolutely chef's kiss, mwah, impeccable. This is a sample I wanted to show you. You can see from the green line here, the start of it. If you look at the flow rate, it's nice and flat on top. The pressure, you can see that the IPAP setting is kind of stuck at 15 there. That whole section is beautiful. There were some other examples on a different night. I actually saw them after I recorded this, but this is what I wanted to show you. So I've had a lot of people say, how can I get my breathing like this? And I can say, well, you can change to a bi-level in S mode. Now, would a bi-level in V auto mode work? No, the algorithm is still really, really poor at picking up those subtle sleep disorder and breathing events and increasing to the pressure. So a fixed level of bi-level I have found to be the best treatment for upper airway resistance syndrome. Now, let me tell you a silly story from my past. Back in the day, back when I was working in an actual lab, there's a physician there named Dr. Robert Diaz. He's a neurologist, he's boarded in sleep medicine, he is a sleep doctor. He's a very good one as well. And he's a hell of a nice guy. Now that said, in the sleep lab I worked, a lot of the job functions during the day were to score sleep studies, and we would see a lot of the studies come back, we'd see what their diagnosis was, and we'd see what the treatment recommendations were. Now a lot of these people that were in the mild range, Dr. Diaz would prescribe bi-level for them. And many of us in the lab, myself included, would say, actually I think everyone, bi-level? Why would you use bi-level on something so small? It's just upper airway resistance syndrome. It's super mild. That should require a small amount of pressure. Well, Dr. Diaz was right all along. I remember one time I asked him, hey, why are you doing bi-level for all of these people that have very mild events? And he said, it's much better control. That's all he said, it's much better control. And I completely understand what he means by that. So the reasoning behind why bi-level works is you have this concentric collapse. That's a lot of stuff to move out of the way. And the reason bi-level works so much better than CPAP is CPAP, we can increase the pressure all we want, but it's just gonna kind of slowly open up that airway. It's not gonna open it up all the way. And every time we exhale, it's gonna slightly collapse a little more, slightly collapse, so you never really get it fully open. Now the reason bi-level works so well, let's use a bad analogy of just jumping off the ground. CPAP is like jumping off the ground. It's static, you jump, you're not jumping all that high, or maybe you're jumping kind of high. But if you add bi-level, if you add a trampoline, now you're gonna get a lot more assistance in holding open your airway or opening your airway up. So every time you exhale, now you inhale, the machine ramps up as you're ramping up. So you're trying to breathe, you're getting assistance from bi-level, and now that airway really opens up every single time at a predictable rate. So in that way, in treating upper airway resistance syndrome, bi-level is much more effective in what I have found. And why that differs from ASV is because it's increasing at a predictable amount every single time versus ASV might be coming here, or maybe here, and every now and then it gets stuck here. And those are the parts that are much, much better. The parts where ASV is not hitting that target rate that appears to be optimal, breathing doesn't look so good. There's a lot of awakenings from what appear to be respiratory effort related arousals, which is what's behind upper airway resistance syndrome. I know that was a lot of information. I'm gonna leave it with this. If you feel like you suffer from upper airway resistance syndrome, you're definitely not alone, and it is definitely something that is treatable. I've seen it a lot. I would say most of the PAP analysis I do with people tends to be upper airway resistance syndrome. A lot of these people actually had severe obstructive apnea, and in their treatment with CPAP, that severe obstructive apnea goes away, but up to a certain point. So let's say the obstructive apnea ends at 10. Let's just get rid of that slight residual respiratory disturbance index, residual meaning left over. If we increase a little more to 12, it's still there, it's still the same. Let's go ahead and increase to 14. Well, it still looks the same. Okay, let's go ahead and increase to 15. It still looks the same. 16, still the same. You can add things like EPR at this point. Oftentimes it needs to happen, but that's not bi-level. It's not the same. And so eventually you do have to switch these people to bi-level to get that trampoline effect, to get that pressure support, to get that assistance in breathing. All right, guys, I think that's about as basic as we can keep this for now without getting too confusing. If you enjoy this video, you enjoy this kind of content, do me a favor, like the video, subscribe to my channel. Check out the sponsor of this video, cpapsupplies.com. Hey, Christmas is coming. Don't be afraid to use my Amazon affiliate link. And I want to thank all the Patreon supporters as well as YouTube members for the support of this channel. And with this, I welcome all comments in that comment section. That's what it's for. Especially from Dr. Barry Krakow. I want to get your input on this if you happen to see this video, as well as people that have sampled ASV and have changed to bi-level S mode. What did you find was the better treatment for you if you have known upper airway resistance syndrome? Let's go ahead and kill this video now. Thank you for watching. Have a great night. Bye.
Oh my god, the video is like so long. Why can't you just do a YouTube short? Excuse me, Johnson? You have no female viewers? That's very unrealistic.
Why you make this video so long, Lanky? Look at me, I'm a dude with a short attention span. I gotta dress up like a dog just to get some extra stimulation.
Excuse me, everybody? Johnson wanted you to know that this video is long because sometimes life can't be summarized in a YouTube short.
Clean your stinky mask with some Mask Bright, available at Amazon. Thank you to all watching, but an extra thick thanks, buddy, to Doug Toombs, Jason Georgiades, Patricia Espelong, Sarvesh Joshi, Stuart Hetherington, Mona Swearingen, Chengtu Chen, Edward Steiner, Deborah Permute, and Shannon Kerr, and another slightly less thick thanks, buddy, to all the other YouTube members, Patreon supporters,